you know, a lot of my cases are post-traumatic. I'm sure, Mitch, same thing. The congenital ones, you're not really too worried. Well, this is interesting. The congenital ones, you're not worried about infection so much, right? When you put a nail in, unless they have had a previous external fixator as a child where there's some residual infection harbored in that bone. And, you know, John Herzenberg is always pointing this out, that, you know, if a kid had a lengthening with a monolateral frame or something, and then you go to do an internal lengthening nail 5 years later, there's a chance that that will get infected, your nail will get infected. So there's one, you know, scenario where you'd be a little bit concerned about this. What can I do to sterilize that canal today during my surgery so I don't have to worry about it? And then the other scenario is post-infection, right? You have a malunion that was previously infected, the infection's burned out, but you know, I'm going to put a nail in there and lengthen, and you know, I'm going to create a lot of blood flow to the area. I may kick up something in there that's bad, right? So what can I do to mitigate the chance of reinfection? So that is, you can put something in the canal that has antibiotics in it. So why not just push antibiotics in the canal? Well, you know, it's going to be there for 20 minutes, right? An hour, and then it's gone. What if you put it into an absorbable slush or paste that elutes for 6 weeks? That gives you 6 weeks of protection. Now, the MICs, we don't know how long they're above level, but it's a lot of studies will show it's at least 2 weeks of elution above MIC, and then it slowly comes down. So that's what this is about, how to make this technique safe in cases where you're concerned that you could get an infection. If you have a florid infection, then don't use this technique. I think maybe that needs to be said as well. Okay, so you know what's been done in the past are coating nails with antibiotic cement, right? So you take PMMA, bone cement, load it with antibiotics of your choice, have to be heat stable, right? And coat your nail with it, which is still fairly new technique where you take like a 10 millimeter locking nail, normal intramedullary nail, coat it with cement and use it in the femur or the tibia as a way of preventing infection once in one of these high risk cases. So, you know, when would you want to use it? Again, converting from an X-fix to an internal fixator. Say you have a patient who's in an external fixator and you want to remove it the same day and put a nail in the same day, you need some sort of protection, right? So antibiotic-coated nail has been a workhorse for us. It's been very good. History of infection, history of X-fix after lengthening, non-union exchange nailing, right? It may seem quiet, but Dr. Helfit et al. Showed that 20% of those cases are culture positive. Negative ESR, negative CRP, no clinical signs of infection, 20% culture positive. Okay. And open fractures, I don't know. I don't deal with a lot of those. That may be a case where you want to use an antibiotic-coated nail in some cases. So here's an example of converting from an external fixator to an internal fixator in one shot. 68-year-old male, he failed a total knee. He's a horrible candidate for a revision. Fortunately, he has a lot of bone stock, so he's got some chance of healing this. He goes into an external fixator to sterilize the area, to compress him. His CAT scan shows some spot welding. He's already been in the frame for over 3 months, and he's torturing me every day about getting it off, and I'm like, finally had enough. So I'm going to convert him to a nail. I should have left the frame on longer. Okay, I'm going to convert him to a nail, but to do it safely, I need to coat it with antibiotic cement. So this was the classic way in our practice. You'd coat this with PMMA, with Vanco and Tobra, take the frame off and put this in at the same time. A very high success rate with this, very few infections. How many infections? I don't know. Asim will tell us in his publication, which is being submitted soon. But it was less than like 10%. So PMMA coated IM nails, well established for infection control, right? So this has been around. This is not new. It's a good technique. How do we do it? Well, we'd use a thick tubing that's used in plumbing that's silicone based. Okay, it's called Tygon tubing. It's a 1/2 inch inner diameter. You fill it with PMMA that you've mixed antibiotics into at a high concentration, and then you push your nail into it. The nail really can't be bigger than a 10 in order to get enough of a cement mantle that it won't just crack easily, right? That's the basic overview of that. It looks something like this. You pump this cement into the silicone tubing, you push your nail in, and then you get a nice coating, and you just bullet shape the tip, and you're good to go. So what's wrong with this? Well, the Precise nail came out, and we realized we probably can't do that to the Precise and expect it to lengthen and break through the cement mantle. And yeah, so we had to find something else. So, you know, necessity is the mother of invention, and we had to invent something else. So independently at a few different centers, we all kind of came up with the idea of let's use something absorbable, but totally absorbable. There's so many products on the market. So calcium sulfate's totally absorbable. It takes about 6 weeks to resorb, slightly longer based on how you mix it. Let's put antibiotics in this thing, and let's try that for these cases. One study here showed clinical equivalence to PMMA. Other studies have shown superior elution. Theoretically, if you have a chunk of cement, PMMA, cement, with antibiotic, as the surface antibiotic eludes, you're never going to get elution from the middle of the piece of cement. How's it going to elude? It can't just travel through the cement freely, like no problem. If you have a piece of absorbable cement that dissolves and unleashes antibiotic as it's dissolving, you're going to get elution for a much longer time, right? So it makes sense that you get a higher elution from something that dissolves and breaks down. So what are the absorbables? Also, you don't need heat stable antibiotics anymore. You just need something that won't make it take forever to set. So that becomes the other issue with it. But so you have a larger variety of antibiotics you can mix. You can use a full-size nail. If I take this antibiotic calcium sulfate and leave it kind of wet, pasty, fill the canal, push my nail in, now I can get an 11 nail, a 12 nail. I don't need to worry about my cement mantle. I don't care about my cement mantle. I'm just going to push this stuff in. It's going to push into the bone, and it's going to cover everything. So there's some advantages to this, right? So how do I use it? Well, here's a patient he's a bit of a train wreck as far as health. Insulin dependent, diabetes, end stage renal. He's on hemodialysis. He has osteomyelitis. He has a bone defect. He's 71 years old. So physiologic, older than 71, right? He's like an 80-year-old, 80 something, right? So he's a bit of a mess, but we have to heal his leg. So we're going for a low bar here. Let's just shorten him and get him healed, right? Nothing fancy. He's not a bone transport candidate. He's not going to make regenerate. This is not a good idea here. So resect fibula, gradually dock him down. And now I want to convert to a nail. So I like to use compression nails for fractures I think they're going to not heal or take forever to heal. So I converted him over to a compression nail. I gave him a frame holiday, and within 2 weeks, his bone cracked in the cast. Not too surprising. But he just had an X-Fix on, right? He has a history of osteomyelitis. I got to do something before I put this nail in. So we pump the cement in there. It's a paste. Pump it in with a chest tube and a Toomey syringe. Fill the canal. Push the nail past it, and then put compression on the nail. And he went on to heal. He was able to put full weight on this right away. Wasn't the greatest walker in the world, but he was allowed to put full weight. So what's the technique? How do we actually do it? So typically for a tibia or a femur, I'll use 3 packs of what Stimulan, actually the company's here today. But instead of the beads, which they show you, it's off-label use. We use the powder, mix the antibiotics in it ourselves. In Europe, it comes pre-mixed with antibiotics at high doses. In the US, the FDA won't allow it still, but you can mix it yourself in the operating room. Put Vanco and Tobra in, and add a little extra water until it's the right consistency, okay? It's important to add Vanco and Tobra. It's important not to add too much Tobra. So there is a recipe that's out there that I can get anyone who's interested, but it's basically half the Tobra you would normally add and the full amount of Vanco you would normally add to PMMA. So the Tobra helps it so it doesn't set too fast. If you use too much Tobra, it sets too fast. It takes forever to set if you use too much Tobra. Put it into a syringe, and then you put it into this, and then I like to backfill the canal. So here's, in this case, it's a retrograde nail. Push it all the way down, backfill the canal, and then put your nail in. Another interesting application of this, this is a weird case. This guy had an open fracture, was treated with this frame, and then someone put him into a hexapod frame 2 days later, and then converted him to a nail, which is kind of nuts, honestly. It's, in the sense that that's a big waste of money. Even for HSS, that would be a big waste of money. So 12 days later, they threw away the hexapod and then put him in and then nailed him, which is fine. Unfortunately, he ended up with a non-union. It was an open fracture, benign, CRP, ESR were negative, no signs of infection, never had a history of infection. So I said, well, you never know. So I did an exchange nailing with a compression nail. He had to get back to work as a manual laborer. He's like, I can't be out of work anymore, man. Like, you got to do something that's going to work. So instead of just doing exchange nailing, I did a compression nail. I put the paste in. Turned out that he grew out 6 out of 6 staph. So this is exactly one of those culture positive 20%ers. So we put him on antibiotics, did the compression nail, and I was very happy that I had loaded his canal with local antibiotic just to blast that staph. Another application of this is pretty cool, I think, is if you get rid of it, you're taking a nail out and using a frame, you can load the dead space with this stuff. In which case you'd add less water and make it a little heftier paste. So you can see this dead bone here. I mean, I thought this was an amazing CT for resonance. Look at this piece of bone. It is like blindingly white. So this guy had like 5 exchange nailings and was never healing. And, obviously there's dead bone when they have that history, but we were able to see it so well on CT. So we basically resected the dead bone and took his nail out. It was an antibiotic coated nail. Took his nail out and then filled his canal with this stuff. And you can see the canal's full of the paste. And I treated him with a frame, did a 2-level bone transport, and he did great. But it was a really nice way, I thought, to treat the dead space. The only data we have on this, I'm going to just jump right to the data. This is all done with precise nails. And basically, we had 0 post-op infections using this in cases that had all had previous external fixators or previous infection. So it seems to be good. This is very limited data. We need to do a bigger data collection because now we have probably 50 patients and confirm that it's safe, that we're beating the infection, and confirm it's just as good as a PMMA or better. Thanks.